Thank you for these kind words, and it's really a privilege and an honor for me to be speaking to everyone. I'm Jihad, and definitely dedicated my career to curriculum ischemia for good reasons, actually. And I'm hoping that I can relate that to you today. So, curriculum ischemia is a term that we use, or CLTI, depends your specialty, has really more impact on life and our patient's life than we think. Some are disclosures, there's no association with the talk. So recently, we joined forces with the American Diabetes Association, and we have a joint venture right now through the CLI Society. One of the things that was a little bit surprising to us to find is the problem of PAD or advanced PAD, which is a term for CLI now, is the number of millions of Americans that are involved with the disease is on the rise for the first time over actually 3 decades. It's going up by 2% per year. But not only that, 1 in 10 Americans do have PAD over the age of 40. And this is a problem because in the past, this number 40 used to be 60. And also 1 in 3 have diabetes. And again, the number has changed, and now it's actually 40 as well. So this is likely to continue to increase the risk of diabetes. Risk of diabetes continue to increase risk of PAD and advanced PAD itself with time. We published many papers, and this is some of the work that we did, and somebody else repeated it as well. And we appreciate anyone that actually does sort of share with us some of our work and make it look better. In here, when you look at the PAD in terms of in the United States, and compare it to many other diseases, we never thought that actually we would find PAD to be deadlier than coronary artery disease. This is the latest finding that we found, because we focus primarily on coronary artery disease as being the major killer. But advanced PAD and PAD are much bigger killer, especially curriculum ischemia, and not only coronary disease, but also cancer. And this number 5 here indicates 24 cancers that we actually checked in our publications. So CLI kills more patients than 24 different types of cancers combined. The symptoms of PAD, lower extremity pain, claudication. The atypical pain actually is the one that we're trying hard to emphasize more and more on it, because we always think of ischemic rest pain as being the primary complaint, but really we have to start to think about numbness, tingling, heaviness, cramping, etc. These are the symptoms that are happening, and we're not catching on to them as quickly as possible. Severe diffuse pain also is being mistaken for arthritis. Non-healing ulcer and wounds is usually things have gone too far. Discoloration and gangrene are bad. And I'll show you why actually this is so important that you catch it early, because the difference in mortality between the 3 is so significant that you want to catch it as early as possible. We're currently working on a big paper, 850,000 patients for a premier database. We're trying to look at the risk factors for PAD and how would they impact our patients. We're looking at age, diabetes, kidney disease, smoking, but CKD in particular. And as you can see, the advanced age continue to be on the rise, and the number of patients with diabetes, as I mentioned earlier, is going up by 2% per year, and it's associated by a 2% increase in amputation, and also increased by 2% increase in mortality. And not many diseases can give you that year after year for 4 years. Then you add on top of that chronic kidney disease, especially CKD4 and up. The prevalence is approximately 14% of the US population. So the high blood pressure, diabetes, and are one of the main causes of CKD. So controlling the comorbidities is extremely important in our patient populations. Smoking is definitely a challenge for all of us to have our patients quit. But I think we should continue to make an effort because it does make a difference. And I want to mention awareness. There isn't a place I go to that I don't talk about awareness, because awareness is really important. And it was really eye-opener for us in the recent publications that we put out to find how much primary care physicians are not aware of CLI and PAD. And it's not anyone's fault, actually, because I sympathize actually significantly with primary care physicians, because they have so much to do in 15 minutes. So they can't squeeze everything in. So maybe we can help them out by raising the awareness and educate them. PAD is progressive, and there's two different classifications that you can use. In the US, primarily we use the Rutherford class, 0 to 6. Now, there's conflicting messages here and there about claudicants and when to treat them and how to treat them, etc. I'll leave that alone for now, but in terms of critical limb ischemia, from 4 to 6, you got to treat that yesterday. And the reason I say that, because if you don't treat patients with CLI ASAP as soon as possible, as soon as you meet them, as soon as they come to the ER, especially those that have a wound, you're actually doing this patient a disservice. And the average time right now between a patient coming to an emergency room with a wound to the first time they see a vascular specialist or get a non-invasive testing is 9 days. And CMS actually has sent a message about the delay. You probably hear about it soon from the Leapfrog group. So advanced PAD, critical limb ischemia, is associated with an increased risk of limb amputation and mortality. And we have really correlated that directly proportional in many different studies that has been published by many authors. And the outcome post lower extremity amputation is devastating for so many different reasons. But some of the reasons are basically, having your family being completely become sort of your advocate, your support group, so their life changes as well. So we'll talk about that later. But in the meantime, once you have an amputation, 27% will have more reamputation within 1 year. I mean, this is 1/3 of a chance that you lose another leg, or maybe the same leg, but more of it. 35% will have a higher level of limb loss. 55% will have a contralateral amputation within 2 to 3 years. And this 55% just went up with the recent publication when you actually look at CLI patients with 5 to up to 80%. Now, the symptoms, we look at rest pain when we're talking to patients, non-healing wound, and gangrene. And the rest pain really has to be defined about 5 to 7 different ways of asking about that question. Please do, because sometimes just numbness, tingling, neuropathy, all of that could be indication of ischemic rest pain, especially in the absence of palpable pulses. You can always do Doppler testing, non-healing wound, and gangrene. Now, the prognosis and the consequences, the CLI is estimated that 5 to 10% of people that with asymptomatic PAD with intermittent claudication would progress to CLI. I mean, that's a significant number. So it's very serious. The study is in 70,000 patients with CLI in the United States. 29% of these patients were either dying or require an amputation within 4 years. We published a study, and when we saw these numbers, we were a little bit shocked, actually. Post-amputation, as we mentioned earlier, 27% will have additional amputations, so we saw that. And then mortality. The 5-year mortality rates following the diagnosis only, of critical limb ischemia is higher than those of myocardial infarction, stroke, and common cancer. So I'm going to pause for a second here to let you think of this. So having just a diagnosis of critical limb ischemia alone, your chance of death in 5 years is higher than the combination of myocardial infarction, stroke, and common cancers, and 24 different kind of cancers. The only cancer that kills more people than CLI is lung cancer. So actually, this is where revascularization procedures, whether it's surgical or endovascular, doesn't matter, has to be the primary approach to patients with critical limb ischemia. And if you don't, you're really doing a disservice to these patients. There's no alternative therapy or alternative methods to CLI except revascularization. There's no such thing as medical therapy. Otherwise, you'll be dealing with mortality rate that's so high. So if left untreated, CLI can lead to amputation. And amputation, depends on the age of the patient, can be associated with mortality automatically. Now, the comorbidity, age, etc. So up to 2 million currently affected with CLI. Each year, more than 160,000 amputations are performed. And this number is expected to be lowered by us. We were asked by CMS through the AHA and ADA, American Diabetes Association, and others, and actually SVS as well. 54% of patients who underwent an amputation were not assessed with a diagnostic angiogram. And that's recent. Some of these studies are recent. There's 52% and there's 50%. So the last study was 2 years ago. So it seems like not too far. So can you believe this? Can you believe like in 2023, patients still get an amputation without a diagnostic angiogram? So endovascular first approach can actually eliminate that. Now, diabetic patients are particularly at risk for amputation. Every 4 minutes, a limb is amputated due to diabetes in the United States. Now, we say due to diabetes because the American Diabetes Association did a great job tracking their patients and see what happens to them. So every 4 minutes, a limb is amputated. And as you know, there's a lot of associated comorbidities that goes along with that. And this is what we see often, and we say it's diabetic neuropathy and diabetic ulcer. We can no longer actually just say so. We have to assess this and see, is this truly a neuropathic ulcer? If it is, then we'll treat it as such, do what we can before it turns into gangrenous disease. The risk factors are, as you can see, down here, and most of our patients do have these risk factors. I appreciated this diagram from Dr. Armstrong and his colleagues. This is the same publication that we published, but what they did is actually they put it in this format. And I like this format better than our publication because it really shows us if you have an amputation, major amputation, or you have critical limb ischemia, your mortality rate is still close to each other. The only thing that would lower the mortality rate of CLI is if you treat it and if you prevent the amputation. Now, the minor amputation, what they added that we didn't have in our study, still have a significant cause of death that is actually almost 1/3 higher than all cancer combined together. So that will give you an idea that CLI in any form, when it presents itself to you, this is something that has to be taken very seriously and has to be addressed and treated very aggressively. And there are many naysayers out there by saying that, well, you're doing too many procedures on a patient with a limb that you may not save or you may save. Well, that's too bad. The naysayers are always going to be there. But, we all have patients that have been with us for 10, 12 years that came to us at the time because it was scheduled for an amputation, but still walking around today or working. So please, I urge you, if you have a patient with CLI, don't be timid. don't listen to anyone. Do what you think is right, which is revascularize those patients, whether it's you're a surgeon or not a surgeon. Any form of revascularization is better than no revascularization. This is really an important slide. I hope you take this to heart. And when you walk away from here today, remember this. Poorest outcome post-amputations are in diabetic patients with PAD. The mortality rate in the perioperative procedure is up to 10%. Open heart surgery is 1%. 1 year is up to 33%. Open heart surgery is up to 5%. 5 year is 81%. I don't want to repeat open heart surgery, what it does, but it's not 81%. Now you can see here, if you have diabetes, the patients tend to do really poorly. And the reason they do, because CLI in diabetic patients does not stop when you treat it. Actually, the disease continues to progress, continue to be aggressive, and therefore it is upon us, all of us here, to keep checking on the patient. And if there's reocclusion or new disease that happens or new blockage, you have to go back in and fix it. And there's no other way around it. Otherwise, the patients, as you can see here, majority of them will be dead. This paper was published by Goodney a while ago, and we are currently working on a similar paper like this, looking at the pockets of the amputation rates, where are the highest in the country. And you guys want to get to win a prize because you do have some high numbers. It's not your fault. It's your patient population. And the expectation is to lower the amputation rate by 20% by 2030. I'm not sure if we can, but I think we should at least all make an effort to lower it. And as you can see here, because of the pockets of high amputation rate in different places, indicates that the patient populations, the disease state, and the southern belt, but also we don't have enough operators that can actually do the proper care for these patients. Racial disparity lead to a high amputation rates in minorities, and this study have been done multiple times. We published about 4 papers on this, and no matter which way we look at it, we still find that Hispanics and African Americans tend to have a significantly higher amputation rate than Caucasians. Now, approximately 2 more likely to be amputated if you're Black versus white, but 50% more likely to be amputated if you're Hispanic. And I know in your area, you probably have a high Hispanic population. So those patients, the reason being, they use the ER as their primary care physician. So by the time they go to the ER, they have gangrene, and it's kind of far more advanced. Now, PAD is challenging in terms of diagnosis properly, and I'm not sure, where do you stand in your institution. I'm sure you guys do a great job. The issue that we're facing, all of us today, is a patient going into a primary care physician and walk out of the office of primary care physician, with a PAD, and the physician does not know that his patient has a PAD, and the patient himself doesn't know they have PAD. So asymptomatic patients are between 20 to 50%. Atypical leg pain is 40 to 50%. The classic claudication is 10 to 35%, and threatened limb is only 1 to 2%. So you see the majority of the patients with serious disease are not aware of the disease. This is from the ACC, AHA, looking at the risk factors to support PAD screening in any of these groups. Patient over 70, and then it goes lower as long as there's diabetes and atherosclerosis, etc. And then with the stock law and other things, as such, to do a PAD screening right now is very complex. So we're expected to do this, but yet we're limited on how to do it. So we're working on that right now with the American Diabetes Associations to bring that back to life. This is an important slide. I think you all know this very well, but it's always important to talk about it because PAD screening test, especially the ABI, although ABI can be falsely elevated in CKD and diabetics, but you will still have to do it. It's a good baseline study. If it's normal, it's less than 0.9. And ABI between 0.91 to 1.3 is considered normal, right? But I'm not sure right now. We're starting to question that point. So there's some of us that believe once it gets above 1.2, it's not normal. That's an offense. Above 1.3, it's silent uncompressible arterial disease, and further testing should be done. And that further testing is definitely something that can be easily performed, especially if a patient has diabetes or CKD disease, because of the classification. So you can use Doppler, TBI, ankle pressure. Even those can be also falsely elevated. So the other testings are the TBI test, segmental pressures, digital waveforms. Exercise testing does not change much with ABI, but TBI has some benefit. TCPO2, it depends on the center that you're in. You all know the calibration of this machine has to be appropriate, but it's a very good test. Ultrasound is becoming more and more valuable, but you have to know how to use it in the tibial arteries. And advanced imaging, we really need to talk about this. It provides clinicians with information that is necessary to plan an intervention. So, for example, CT angiography, MRI, are really important for iliac disease, SFAs, possible popliteals. But beyond that, actually they're not helpful unless you have a specialty or specialized physician in reconstructing MRAs or CTAs. So we did a consensus paper, published it, and it's called the digital subtraction angioplasty DSA angiography DSA. And the DSA showed us that to be the most sensitive and specific on showing patients with CLI. Continue with the physical examination. It is so critical for evaluations. Simple for exam at every visit. Some will say it will take 3 minutes, some will say it take 5 minutes, and it depends on how much you do. But at least if you take a look at the foot, number one, you would see if it's pale, if there's a wound present on it or not, if there's a gangrenous toe or not, and ulcer, etc. And you can try to feel the pulses. You can stop there if you want to. If the pulses are not present, you can just check the Doppler or send the patient for further testing. Diabetic foot risk stratification triage. This one here I'll leave for a second. Probably you can read it later on. This presentation will be yours. The certification and triage is really important. And this is going to be sort of mandated actually because CMS is involved now. And they're asking a lot of questions. They're asking why our patients are dying? Why are they getting amputated? What's going on? And there's a lot of things to say. But, as you can see here, in terms of remission, which is, high, moderate is 17 and low is 76%. So most of these diabetic patients do have some form of active disease. So therefore, we have to really stay on top of it with them. The DSA paper that I mentioned earlier, what we found in this paper, as we did a consensus paper, and that was a really broad review of literature, we found that DSA is the gold standard for CLI diagnosis and treatment strategy because you can see everything all the way to the digital branches, especially when you do a selective DSA. I really encourage you, before a patient goes for an amputation, or if you're trying to get a good answer, to what's going on with the patient, do a DSA evaluation of both legs. The prevalence, prognosis, and variable of care for CLI patients. The global prevalence of PAD is to about 23%, and that's 2010. So this is really interesting because it was 164 to 202, the jump in 10 years. So almost, too much. And this indicates a global pandemic of PAD, and that continued to be on the rise. And actually from this, where the current statistics that I mentioned earlier, because of this, the statistics showed that there's a continuous increase in rise in PAD and diabetes. The presence of the percentage of likely underestimated here, because the true burden of the disease is derived from the community-based studies that are defined by the ABI, right? If the ABI is reduced. Now, if ABI is done and it's not reduced and it's 1.2, 1.1, it's called normal. And if it's 1.3, somebody might call it normal still. So definitely the numbers are much higher than this. Another CLI prevalence issue and prognosis and value of care, the amputation rates in general PAD populations. It says here declining, it's an estimate, declining with an estimated 150,000 amputations due to CLI occurring annually in the United States. Well, this was published in 2013. Now, despite this fact, CLI continued to be the first line of therapy. Sorry, this should be here, actually, amputation, not CLI. Continue to be the first line of therapy for CLI at some institutions that average about 20%. Now, the typo, I apologize for the typo, but actually at 2013, the amputation rate was going down. Dr. Hirsch published this and did a good job. But actually today, the amputation rate is going up by 2% year after year for 4 years in a row. And the age at which patients are getting amputations shifted from 60 to 80 down to 40 to 60. That's a really important point to remember. And this is another actually publication that supported the concept later on of CLI prevalence, which is patients undergoing primary amputation, 73% do not have a diagnostic angiogram. And that's really, really concerning to see something like this. And 54% receive no revascularization attempts prior to amputation. And although, I have the privilege of being involved with CMS right now and American Diabetes Association, we discuss this on a regular basis. We get to be the one that in the front line, hearing the words, how could you let this happen? I mean, it's really hard to change habits, right? But hopefully altogether we can change this a little bit. This is really sad. 73% do not have a diagnostic angiography prior to amputation. 2016, the AHA stepped up a little bit and then did say that you must evaluate these patients for the revascularization option. It should be performed, and the multidisciplinary team was put in place to prevent amputation. So if a patient is going for an amputation, anybody in the hospital that feel they can do something for that patient, you should step up and say, I can give it a shot and see if I can prevent an amputation. I know this is not as easy as it sounds, but we implemented that in our hospital. And initially there was a lot of, negative interactions, but that changed later on because we started to see positive outcomes for patients that were going for an amputation. And then when they got therapy, the amputation was prevented. So it does work. I definitely want to share with you here the joint guideline of the SVS, ESVS, WFVS, which states that no patient with suspected CLI who is a suitable candidate for limb salvage should be denied revascularization with that first and the complete diagnostic angiography that includes the ankle and the foot. Now, this was just published, and they really did extensive work on this. And it's still, unfortunately, we're still seeing the opposite. So in your institution, you can just implement that there is no amputation allowed unless some form of angiographic attempt in terms of either evaluation by angiography or attempt revascularization should be done first. Time diagnosis treatment are essential to preserve tissue viability in CLI. And this is something that really made a point when it was published, because it showed that, the earlier you treat patients, the less likely to have a major amputation or actually any form of amputation, possibly even toes. The AHA followed this by saying that the effective expectation is the pressure by doing pursue invasive angiography with endovascular revascularization directly without any delays. And this is where the endovascular first came from. And then, of course, any form of diagnosis is better than no diagnosis, including non-invasive testing, CTA, etc. And there are clinical scenarios in which non-invasive studies for anatomical assessment could be perceived as confer greater risk of for patient-invasive angiography. So, you can do a ultrasound for patient with CKD. And as you know, ultrasound can help you a lot, but the physical exam itself can tell you so much more. And if you need to just do these things one by one, it's fine. But as long as the end result is you go in and do something for this patient by doing some form of revascularization. Here's the limitation of CTA and MRA for BTK disease. You can see here the CTA image of the tibial vessels is limited because of the calcification. You might think that there's true vessel runoff to the foot here, where the MRA with that contrast demonstrated lack of tibial resolution. So, which one do you believe here? And the angiography will show something completely different. So first line CLI treatment is limb preservation, not primary amputation, and that should be everyone's goal. And the average time to revascularization for CLI patient right now is 9 days. This is unacceptable when the disease has such high mortality and morbidity and mortality. Now, when we get a call from a physician about a patient with CLI with gangrenous toe, we know that gangrenous toe is associated with significantly high mortality rate, significant. We take that patient the same day if we can, or the second day, and therapy is delivered within 24 hours from seeing the patient, and sometimes the same day. Again, CLI implies chronicity and should be distinguished from acute limb ischemia. All treatments guidelines from ASVS indicate that DSA is a standard investigation for ALI, since it can actually delineate etiology and offers advantage for treatment in the same setting. Knowing where the source of problem is always very helpful. There is urgency to proceed with treatment for CLI, but not without proceeding with the multidisciplinary team evaluation. It's always nice to sit and discuss a case patient with critical limb ischemia at risk for amputation with someone else, because any little advice, any little help can actually make a big difference in someone's life in terms of saving their lives. So expert recommendation statement to optimize limb salvage. The CLI Global Society believes the following recommendation may help reduce the incidence of primary amputation in CLI population, resulting in better outcome and lower burden on the society. So, number one, primary amputation should not be the first line of treatment for CLI unless there are mitigated circumstances like life-threatening sepsis, intracranial infection, etc. Ideally, multidisciplinary team, a specialty care team should determine if CLI limb is salvageable. And I bet you just any two of you can sit together and can determine this. And but one person alone cannot, because if that person just knows how to amputate, is going to amputate the leg. If that person knows how to do a good bypass or good endovascular therapy is going to do that. So it's always good to have two people, at least two, discussing it. The results are always good. DSA is really phenomenal method of seeing the anatomy all the way to the foot. Never actually ignore the foot. Always start with the DSA to the foot. And when you finish therapy, finish with the DSA to the foot. This is the algorithm that's published in our papers. And again, this will be present for you. The algorithm that CLI Global Society put together here is actually in conjunction with the multidisciplinary specialty team evaluation that can prevent unnecessary amputations or minimize amputation level CLI patients. What we did is we looked at every society's recommendations on how to treat patients with CLI and combine them together and reduce them to this simple, small algorithm. So you can actually make a copy of this small laminated, put in your pocket. It's very small, and this is combining all the other societies and their recommendations. Accurate DSA angiography is definitely critical in making the right treatment decision for CLI patients. Now, non-selective DSA of the SFA versus selective. Now, DSA of the SFA and popliteal arteries show the proximal occlusion here in the middle and the distal reconstitution. The example here showing that the limitation of DSA visualization of distal arteries without selective angiography versus with selective DSA can determine the anatomical configuration of arteries not visualized beyond, which is the three-vessel runoff. So in some of these cases, sometimes we stop and call our colleague in vascular surgery and say, hey, this patient initially CTA did not show any runoff to the foot, but there's three-vessel runoff. This patient is only, 65 years old and can benefit from bypass surgery. There's nothing wrong with actually doing that, stopping and sending the patient to surgery or go ahead and treat the patient. But I just want to show you the difference when you do a DSA all the way to the foot, the kind of things that you can find. Summary of key DSA points. Primary amputation should not be the first line of treatment for CLI unless there is mitigating circumstances. Ideally, the multidisciplinary team should determine if a CLI limb is salvageable. DSA is considered a standard of care in many societies. Also, DSA includes the ankle and the foot before and during diagnostic and post-intervention. And the risk of DSA should be carefully considered for patients with CKD. And the way you can do that by actually having a selective angiogram with an O1/8 catheter. So despite recent guidelines updates on PAD and CLI treatment, standard of care for CLI is still not uniform. As a result, contemporary management of CLI patients is highly variable. And I'm really happy to be sharing this with you because this is a reality that we live in today. Despite the seriousness and the serious morbidity and mortality associated with CLI, we're still unable to actually make it uniform, although we're working on it very hard. So that is resulting in a primary amputation prior to exploring options for patients, even with multidisciplinary teams. So multidisciplinary teams do have a great outcomes. But like families, there are places where they have great teams, and there are places they have okay teams, and there are places they have teams that don't do so well together. So I'm hoping that one day we'll all have great teams. More important, CLI patients with BTK disease can fail to receive definitive imaging evaluations, and those patients have the unfortunate outcomes. The Global CLI Society calls for a true interdisciplinary assessment prior to an amputation using selective DSA as a definitive imaging modality prior to amputation. This is very nice slide. I showed you some earlier slide with diabetes. This is actually a paper that we published in 2019. We found that 78% of amputated patients are dead in 4 years. And we looked at 4 years instead of 5 because we wanted to see, what happens. The ICD, this was using ICD-9, ICD-9. ICD-10 was not available yet. So what happens at 4 years? And notice if you have gangrene, what happens? I mean, it drops quickly and the patients die very quick. Wound care, wound and rest pain have similar outcome. Still not the best, right? Patients still die. So above the ankle amputation was associated with much worse outcome versus any form of revascularization. So you've got to do something about these patients when you have them, especially if you present with a gangrenous toe in your institution. That patient is an emergent patient, should be admitted to the hospital, placed on proper medications, and some form of revascularization should be done within 24 hours. Because amputation is deadly, and a recent meta-analysis published in Vascular Surgery reported 3-year mortality risk of 71% after lower extremity amputation. So it's getting worse because now our patients are living longer, they have more comorbidities. So please take this really into consideration now when you see a patient with critical limb ischemia coming to your institution, and treat them as soon as you can. Because if you don't, and if they get an amputation, 7 out of 10 patients are going to be dead within 3 years. I mean, this is really getting too serious to be ignored. More patients die from CLI than all cancers, except for lung cancer. And this is a nice paper to look at when you get a chance. Dr. Armstrong and Conti put it together, similar to our paper that we published just about a year before that. I like this diagram better because it's self-explanatory. This is our diagram that we published. We did a more specific statistical analysis up to 5 years. And we found that the relationship of 5-year mortality rate and annual incidence cases of CLI and 22 common cancers. So we applied this together with an absolute number of death within 5 years among these patients. And unfortunately, it is directly proportional. So on a presentation, so one would expect patients and healthcare providers are well aware of it because numbers don't lie here. And we did this in many different ways. We came up with the same results. And I'm glad that Dr. Armstrong and Conti repeated the study and they found the same result, no difference. Wrong, they're not aware. This is really another publications that were done. 75% of people at the age of 50 and older do not know about PAD. And this was really a great study to ask the patient, what is PAD? And if they're over the age of 50. And 51% of primary care physicians are not aware of PAD diagnosis among the patients who have PAD. And some will call this as a crime. I'm a little bit less hostile to call it a crime. I would just say, there's not enough awareness, not enough of us dealing with CLI and talking about it as often as we should, and PAD as well. So primary care physicians have a lot to deal with, so we need to help them and make them aware of this. So if patients and physicians are not aware, how will we ever tackle this deadly disease? Because I mentioned to you, for the first time in 30 years, we have an increase of amputation and death because of this disease over the last 4 years. So a call to action that was put out, and this is something that is expected to be done from you, from me, from everyone. We're all going to be graded actually in 2030, and we probably are getting graded as we speak. I happen to be sitting on a Leapfrog committee right now, and we discuss different hospitals and who is having an increased amputation, who is having decreased amputations, and who's implementing certain things. So we need to keep talking about CLI and not just talking about it, implementing programs in place. But for example, simple implementation that you can do in your institution, just a patient coming to the ER with a gangrenous toe or an ulcer, ischemic ulcer in gangrenous toe, they should be actually admitted and treated right away. They don't. They get sent home. Diabetic patients are at a constant risk of amputation, and that this is something that you really should be able to say comfortably on your rounds, talking to your patients. Anytime you have a chance to say that statement, say it. They are at a constant risk for amputation. There are no guidelines to support close follow-up for these patients, including non-invasive testing. There isn't. Actually, we looked everywhere. And this is our problem. And we end up actually doing the testing on our own. And you can't bill for it, which is fine. Money is not everything. But at least you know where your patients stand. And diabetic patients are very special patients, and CLI patients are special as well. So if they have diabetes and CLI, that's a bad combination. 70% of diabetic patients do not receive ADA recommended therapy. The American Diabetes Association is definitely not happy with this. And the reason being because the ADA recommendations is something that was worked on very hard to be put in place because it does make a difference. So the ADA recommends regular foot care for individuals with diabetes. Yeah, only 30% of eligible patients actually receive it. I was guilty of this myself about 4 years ago, but 4 years ago until today, I'm not. I do actually do the exam. And the solution is start talking to your colleagues about it and to your patients. And tell your patients, next time when you come here, remind me to examine your feet again. Actually, I do that. I do say that to my patients, and they remind me. But I definitely do it. CLI awareness must be raised. I cannot say enough about awareness. I got to tell you, it does make a big difference. And now, in 2013, President Obama signed an act to develop nationwide plans to address the nation's deadliest cancers, which resulted in drastically improved outcomes. We need to do the same for CLI. Believe me, we're working on that day and night. Hopefully, you all can join us in this by joining the CLI Society, because the way this was done is by combining a large number of physicians from oncology, all different oncology, and then they went to the president and his constituents, and they were able to do it. So if you get a chance to join the CLI Society, please do. We need numbers. We're over 1,000 now, and the more we have, the more likelihood that we get this. So we need a coordinated and comprehensive national plan to address all aspects of CLI. Don't read all of this, please. You're going to have it. This looks pretty, but we're not there yet. We would love to get there. Policymakers, right upper corner. And I used to think we as doctors, the one that make a difference. Then as you work in institutions and you start to interact with payers and policymakers, you realize like your passion and your love for what you do, you want to move mountains to care of your patients. And I know you all feel the same. And it kills me every day when I cannot provide my patients with samples of medications, or they can't afford the drugs, or etc. But I believe, and I'm optimistic, that if we all get together, combine our effort together, and work together, we can achieve this. This is why I'm asking you to join the CLI Society. The American Diabetes ADA, Amputation Prevention Alliance. Again, I am very privileged to be part of this. The one thing that really, really still surprised me when I read, 85% of amputations are avoidable. Initially, when I heard that number, I had to go look it up because it's when you first hear it, you kind of question: is this really real? Real? It is. So I'm telling you all right now, all of you, 85% of amputations are avoidable, and this is the data that is very well supported by the ADA. So we must partner with policymakers to disrupt this disturbing trend, because talking about it among ourselves not going to make a difference. We need a higher power to help us with that. So the coalition that we're in right now, we are working with policymakers, and we're hoping to stop this. So federal reimbursement policy should reflect a commitment to ensure robust access to service and medical interventions to prevent amputation. As you all know, there's always a constant cuts for physicians that deal with this kind of disease. I don't want to get into that stuff. It's really not, this is not why we're here. We need to still focus on the individuals who has had diabetes-related amputations, has a worse chance of 5-year survival. And these patients die. And amputation should occur only as a last resort option, not a first resort option. In the United States, a limb is amputated nearly every 3 to 4 minutes, actually. And recently, the last number I heard was they're going to reduce it to 2 minutes because of the recent increase over the last 4 years by 2% per year. So I think the number is going to change. So it's 3 to 4 minutes right now, but I think it's going to go down to 2. Preventing amputation requires a team-based approach. And I gotta reemphasize the word team approach. And we don't always have to love each other, or at least we can be collegial with each other. In some institutions, I've seen teams that are phenomenal, and in some institutions, I've seen teams are phenomenal, but there's some tension between that group versus that group, but the outcome is the same if they work together. And that is the message. That is the ADA and the coalition, and CMS actually be part of this, is going to be coming out. So PAD revascularization and referral. This is going to be funny to all of you because it's real. Vascular specialist overview. So what type of physicians can be vascular specialists? Most vascular specialists are vascular surgeons, interventional cardiologists, or interventional radiologists. All of them are all vascular surgeons, cardiologists, radiologists, vascular specialists? The answer is no. The skill level that is required to treat advanced PAD and CLI vary greatly. It is really important to know when to say, I can't do this, I need to refer this patient somewhere else. So the example that's going to be funny to you is that we have a hospital here, probably like a nautical mile away from us. They would never refer a patient to us for limb salvage, but we get a patient constantly. We get patients from Hawaii all the way to here for limb salvage. So I find that funny in a negative, in sad way, actually. Sorry, 1 mile away we don't get a patient, but we get patients from Hawaii all the way to here, and we do save the limbs, and we follow them through the cardiologist, vascular surgeon, etc. Where do vascular specialists practice? They're in hospitals and in OBLs. OBLs right now are under a lot of fire from many different specialties, but actually the kind of work that's being done in our patient centers, some are very well respected. And then I'm sure, like everywhere else you go, there's always good and bad and everywhere, in hospitals and OBLs. What we need to focus on is where can we find someone that can help our patients and send our patients to. Volume does matter, and this is a paper that was published by in Sky. So centers with higher lower extremity revascularization volume, more than 550 per year, are associated with better rate of limb preservation. This is not surprising, as the same is well documented in the coronary space. And in terms of CLI, angiogram and revascularizations are realized part of amputation. So amputation is too frequently the first and only therapy for CLI. And two different publications here showing so. More than 50% of patients don't receive an angiogram, even though they reduce the odds of amputation by 90%. So if you just get an angiogram, you might see something that would lower the risk of amputation by 90%. So imagine you're a patient that just received an amputation without an angiogram. If the same patient had an angiogram done, there's a 90% chance the amputation could have been prevented. So please take that to heart. This is real data. And then the 54% CLI amputation without anything else, that still breaks my heart. Interventions to treat PAD and CLI, endovascular vascularization, angioplasty, stents and atherectomy, surgical hybrid revascularization, emergent novel treatment. There's some really great technologies that are coming out today. The goal here is to minimize the number of amputations and the location of amputations. So losing a toe is better than losing, 4 foot, and then better than losing a BTK. And sometimes a toe amputation is a win if the rest of the foot and the leg are saved. The long-awaited BEST CLI trial recently published. The BEST CLI showed a better outcome for patients who underwent surgical bypass in patient population who qualify for both surgery and endovascular vascularization. We just published a paper in a journal of CLI with multidisciplinary team, all specialties from the United States and around the globe. Everybody gave their opinion, and hopefully you get a chance to read this. How will the result of the CLI change CLI practice? The answer remains unclear. The trial enrolled subjects that qualify for both surgery and endovascular revascularization. The majority of CLI and limb salvage patients have multi-vessel, multi-level disease, and significant comorbidities causing them to be poor surgical candidates. Many CLI patients do not have adequate healthy distal target to accommodate bypass. So the goal of revascularization is for life limb, limiting claudication, symptom relief, improve walking, and reduce risk of heart attack and stroke. But the goal for CLI patients is limb salvage and life preservation. I mean, there's a big difference here, and we always have to differentiate between the two. I don't treat claudications. I've not seen actually a non-CTO lesion for years now. And we need to take this CLI word or CLTI word very seriously. And we need to take the non-healing wounds very seriously. Extension of ability of patients to live a full life is possible. We're doing it, we've seen it. And I hope you can share my enthusiasm. So what is possible? These are patients that, presented with no hope except for amputation, and they all did well, and the reason they do well because of people like you who are willing to put and make the effort to raise awareness, talk to other physicians, do an angiogram, attempt revascularization prior to amputation. On the left, it looks really bad, but on the right, it looks really good. And some of these patients can stay without a problem for a long time. CLI treatment is a team effort. It's never a single individual. And, the circles, you all know that by heart by now. So don't feel like you're alone in this. We're all in it together. And we have to always think this way. Call the wound clinic in a week after you send your patient there after revascularization, or call anyone else seeing the patient, check on him. It really helps. After revascularization patients with wounds, I always make sure that they get in the care that they need immediately, especially if they're going to put a graft on. Vascular specialists understand the value of what must happen after revascularization. So optimal therapy, physical and occupational therapy, wound care is so precious. Post-revasc surveillance, that is really critical. And of course, patient education and expectation. Patients are not aware how serious their illness is. They're not. So we have to really explain it to them in our consent form. Happy to share it with you if you want. I can ask you for that. we do have a significant amount of information in there and data to explain to them. So remember, despite wound healing, the patient is not cured, right? CLI is not a curable disease, it's a curable disease. So CLI is an ongoing disease. So despite the fact that you just fix everything and the wound's healed, this patient still has CLI. What if vascular specialists recommend amputations? Well, seek a second opinion. And that's what I was, when I finish my case, I make pictures of the patients. I put my name and my cell phone number, personal cell phone number on it. So if they go somewhere, to have the physician call me and ask me any questions. And you don't have to do the same thing I do, but at least that will help. Second opinion makes a huge difference because it doesn't show statistically significant difference between limb loss and limb amputation. Most second opinion lead to a limb salvage. So how can we work together to improve the care for CLI patients and severed limbs? Until the amputations rate differential between two centers that are 5 miles apart is equalized, we will continue to lose unnecessary limbs due to lack of CLI specialists. Sorry, I just mentioned to you 85 to 90% of amputated limbs are unnecessary or preventable. And that's not my word. This is the data. It's factual data I'm giving you. It is a crime in 2023 now. Patients are still undergoing amputation in the United States as a first line of therapy. Public health care providers' awareness must be enhanced. CLI Global Society and becoming, please join the CLI Global Society and become a CLI fighter. We need every one of you to help us go and ask for an act to change the current status of the CLI. Here's how you join. Just go to the CLIGlobalSociety.org and become a member, CLI fighter. And together we can make a difference for these patients. No one else is fighting for them, so we can do that. Thank you so much for this opportunity, and it's been a privilege talking to you.